I come in here and I'm on heightened alert. Like, what's happening today? Who do I need to help today? How serious is it? Sometimes it's all just horses. Sometimes that's all I take care of, but occasionally a zebra walks in here and I got to be ready for the zebra. Let me tell you about the zebra that happened the other day. Holy cow. Hey everybody, I'm Lucy Douglas. I'm a family nurse practitioner and I'm owner and CEO of New Beginnings Wellness Center and Spa here in Ruston, Louisiana. I spoke to you previously about the metabolic defect known as insulin resistance. And just a quick review, that is not a problem with your pancreas. Your pancreas at that point is making adequate insulin. It is a problem with your cells and the skeletal muscle, the liver, where your cells are not properly responding to insulin as they're designed to. So that insulin is like a key that comes to the cell with the glucose or the blood sugar molecule attached, opens the door of the cell and allows the sugar to go inside the cell, then to be used for cellular energy, getting that sugar out of the bloodstream, because there's only supposed to be a little bit at any given time floating around in our bloodstream. So you say, well, what's the big deal, Lucy? What does it matter how much sugar is floating in my bloodstream? Well, the therapeutic range for sugar in the blood is quite narrow. It's about 70 to 110. That might differ slightly from person to person, but the non-diabetic person, that's where your blood sugar should be at any given time. So that's not a broad range. And so when we talk about type 2 diabetes and why type 2 diabetes creates such a dramatic increased risk for heart attacks and strokes. Well, what's driving that? Why is that? And why do we see so much diabetes and then those other complications on top? But it is because high blood sugar creates toxins in the blood. And those toxins are chemical toxins, but imagine them as like shards of glass. And if I were to take one of your beautiful coronary arteries out of your heart and I was able to slice it open and lay it out for you like this, the lining is called the endothelium. It's like skin. It's like the skin protecting the lining of your blood vessel. High blood sugar, that chronic toxin in the bloodstream over weeks, months, years, is like shards of glass damaging the endothelium, creating pits and tears. So then over time, I would say the large percentage of time, these patients also have dramatic blood cholesterol abnormalities. They're making tons of particles that are the plaque-forming particles. So imagine, like you drive down the interstate and you see a portion of the interstate closed off. You can't drive on it because they're resurfacing it. So if they're resurfacing with asphalt, say, what's going to fill the space easier? Sand or beach balls? Would you agree that sand is going to fill the space where they're resurfacing much easier than if we dropped a semi-truck full of beach balls on that? Well, you actually make particles that are kind of likened to particles of sand, and then you make larger, buoyant, fluffy particles that I would refer to as beach balls. So if you're making more sandy particles and you've been walking around with high blood sugar for years, either as a pre-diabetic or as a full-blown type 2 diabetic or as a type 1 diabetic that's not been aggressively addressing your disease, then the pits and tears in your endothelium are allowing the sandy particles to penetrate down into the lining of your vessel where plaque is formed. So that's why all this matters. That's why I'm here just like getting red and so intently wanting to share this information with you to keep you from going that direction. So what is prediabetes? Again, as I mentioned about insulin resistance, and I kind of went down this little side path, but it's all up here and sometimes it doesn't totally come out in a perfectly organized fashion. Prediabetes is also a distinct disease state. It is not a benign condition at all. It is a warning sign. It is wah, 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 wah. Your body's going, warning, warning. It's saying, help me, help me. And so please know that that can be identified. It can be fixed. It can be reversed, and you can get off the diabetes train. So if any of my former students happen to hear any of this, give me a thumbs up, because then we'll laugh about my diabetes lectures back in the day. And so what I have found to be the case that's of concern to me is that in many primary care settings where you might be going to get your yearly checkup or even your well woman exam, if you're a woman, and having your pap smear, that you're getting a very, very simple, very skimming the surface few blood tests, not really giving you very much feedback on your internal environment. And so we mentioned in the previous video, one of the signs of insulin resistance is that your fasting blood sugar would be greater than 100. So we can diagnose prediabetes via the fasting blood sugar. So it would be called impaired fasting glucose, and it would be from 101 to 125. So if you see on a blood report, and you need to be asking for your copies so that you can monitor trends over time. So if I see someone that has impaired fasting glucose of, say, their blood sugar comes back 120, well, I would not make a diagnosis on that one value of prediabetes. I would want to recheck it, say, in a month. But there's also another blood test that I want you to be aware of. It may or may not be being done as a matter of a wellness screening in every area. And it might be something you need to ask for. It's called a hemoglobin A1C. So what the A1C is capturing that's so valuable is it's capturing all of those day-to-day fluctuations that we might all have in our blood sugar in response to what we're eating. And it captures kind of that trend of fluctuation over about a 2 to 3 month period. And it's an extremely useful tool. The American Diabetes Association has said for a long time now that we as providers can use this tool to screen your overall glucose sensitivity and health, of how well are we doing over time with blood sugar. Are we having more trends above that 125, or are we staying down below 100? And so the A1C can be a useful complement to the fasting blood sugar, along with other information. Certainly those are not the only two tests I use to determine prediabetes, but those are very accurate and sensitive. So those are going to tell me pretty well, especially if I repeat one or both of them, say in a month or even a couple of weeks, just to kind of confirm what the first test told us. Because certainly we don't want to lose our minds, if it's for some reason a lab anomaly or something like that, which that does happen. And there's certain other things about you that would lead that A1C perhaps not to be the most accurate measurement of your long-term glucose control, but I don't really need to get into that in this video, because that's something I determine one-on-one in each patient interaction, how I kind of go about screening people for your internal health. So knowing your fasting glucose and knowing your hemoglobin A1C are extremely important to determine if you are in this state of being pre-diabetic. Now, if you're a woman listening to this and you had gestational diabetes while pregnant, that automatically confers increased risk upon you for having and developing type 2 diabetes. So please be aware of that. That's just a little aside. I have found that there's a really lack of good follow-up for women that presented gestational diabetes and were properly managed during their pregnancy, but then the discussion ceased, the minute the baby came. And that's not really the right way to go about it. You should have your blood sugar checked 6 weeks postpartum, and I would make sure that your fasting glucose is down below 100 and that your hemoglobin A1C is also in therapeutic range to be sure you're completely past your gestational diabetes and that you were not an undiagnosed type 2 or pre-diabetic and it just came out during the pregnancy. I've actually seen that happen in a patient. Let's talk about the hemoglobin A1C. I explained what the test represents and that we look at it in context of the fasting glucose and some other things. So what does the A1C need to be? The American Diabetes Association has established that we would diagnose type 2 diabetes with an A1C value of 6.5%. Well, you have this range precursor to 6.5, that's 5.7% to 6.4%. That is prediabetes. An example comes to mind where a patient came to me from several hours away, had been being cared for by another provider, and she brought some of that lab work with her to our appointment. Well, this other provider, funny enough, had measured an A1C on her more than one time. Her A1C on this lab work prior to coming to see me was 6.2%. So what did I just tell you the normal range was? Below 5.7. I, Lucy, want your non-diabetic A1C to be less than 5.4. So I'm pretty aggressive. But 5.7 to 6.4 is prediabetes. This provider had circled 6.2 on my lady's lab and written normal. So this lady walked around for however long she walked around until she happened to come to me and had been told by another provider her A1C was normal. That is far from normal. And so that's alarming to me when, as I mentioned, cardiovascular disease, and I mean diabetes when I say that, because diabetes is cardiovascular disease for the reason I previously explained about high blood sugar, how it damages your endothelium and makes you at risk for plaque formation in the lining of your blood vessel. This is science. This is not my opinion. It's well established. So diabetes is cardiovascular disease, and that is what is killing everyone to the tune of greater than 800,000 people in our country every year. To me, that's a lot of people. That's too many in supposedly the most advanced nation on the planet. So that worries me. It actually infuriates me. And so that's why I'm sitting here trying to teach you this, so that you will go and be a rabid, knowledgeable, red-faced advocate for yourself to protect yourself, and that you will expect excellence on the part of your provider, and that they feel on a deep personal level that they are throwing themselves in front of a moving train on your behalf. I feel that way all day, every day. I come in here and I'm on heightened alert, like what's happening today? Who do I need to help today? How serious is it? Sometimes it's all just horses. Sometimes that's all I take care of, but occasionally a zebra walks in here and I gotta be ready for the zebra. Let me tell you about the zebra that happened the other day. Holy cow. This beautiful 47-year-old lady, not horrifically overweight, could maybe lose 10, maybe max 20 pounds. I think kind of many of us are in that predicament. So not a ton of weight, not the worst, tragically terrible lifestyle, not like boxes of Little Debbie's and 12 packs of Coke for lunch. You know, she just wasn't the worst that I've ever seen and talked to. So we do all the yearly labs, and it is some of the scariest I've ever seen. Lipids, total cholesterol, LDL, some of the other particles that I'm checking, some of the yucky ones that are super plaque formers. She had the highest level of ApoB particles I've ever seen. She had genetic risk. That particle is called the Lp(a). She had that. It was quite high, which means on her LDL particles, hers have a weird anomaly that they will form a corkscrew or a pigtail on them, and it causes them to be sticky. So if someone has the LP(a) variant, they're at an increased risk of heart attack and stroke. So her numbers, and she was severely insulin resistant. It just blew my mind because what she presented to me, I was shocked, the severity and seriousness of her numbers. So I actually recommended to her that she go all the way to Lafayette because it's the closest place that I can send someone to have what's called a CIMT test, carotid intima media thickness testing, CIMT. It's a carotid ultrasound of both carotid arteries. It takes 5 minutes. You have various lining in your blood vessel. And so the intima and the media are the second and third level of layer, layer of your blood vessel. So I said plaque forms below the endothelium. It doesn't form here in the lumen of the blood vessel where your blood flows through. It forms down in the lining, and it forms between the intima and the media. So therefore, the purpose of the carotid ultrasound to measure that thickness to see if she has plaque formation. And I said, you've got to go to Lafayette. I have a colleague down there. This is what this girl eats, breathes, and sleeps. We're like this. She and I were like on the same page. And I sent her to my friend, and I get this report back, and she's got double. Her thickness is double what it should be for a woman her age. My colleague told me that her vessels were that of a 90-year-old woman. She told me on the phone, my colleague did. She said, Lucy, you have saved this woman's life. Now, it's just cool that I have contacts like that I have colleagues, and I'm always like on the move, and I'm always trying to find out what's happening out there and where can I send you, and I'm trying to keep y'all from getting dead. And so I said, you've got to go to Lafayette. And she was like, yes, ma'am. And she went. The next thing I know, I have this report on my desk, and I'm on the phone with Deidre going over it because it's my first one. I've known about CIMT testing, and there was nowhere around here to go to get it. And then guess what? This nurse practitioner and I crossed paths, and we live 3 hours apart. So now I'm able to provide this awesome test to if we get yucky numbers back, and especially if there's insulin resistance and or prediabetes, it's already morphed that direction, we are able to intervene. And so this lady required an aggressive approach. And we started her on a pretty good dose of Crestor, and we started her on an older blood sugar medicine called pioglitazone that specifically works in the pancreas to wipe out insulin resistance. We felt like we needed to be aggressive. So you're like, oh my God, Lucy, you prescribed drugs? Darn right I did. Like, I'm not going to be like, here, eat an apple when, she's got these hideous numbers and double the width. She had soft, spongy plaque. That is the plaque that is at risk for rupture. She's got it here. She's got it here. So I'm keeping her out of the funeral home. So yes, I called her immediately. The minute I got off the phone with my colleague, I explained it all to her. I sent in the medicines electronically. Go get them, get started on them in the morning. She met with me yesterday. We went over it again in person. How are you? Like, how's your mental status? Everything's cool. So we put together, she'd already implemented lifestyle changes. I think she'd already lost 6 or 8 pounds, and in our first 4 weeks, since it had been 4 weeks since we had met. So she was already making lifestyle changes before I had that test result back. So I say all that to say this lady had nasty particles, but she was extremely insulin resistant, but her A1C was not yet high enough to indicate prediabetes. It was 1/10 of a point away from being prediabetic. So these are serious problems. And I don't say any of this because I don't ever want to use fear as a motivating factor. That's not where I'm coming from. I'm simply sharing a clinical situation that happened that has relevance here for what we're talking about, and that I'm so grateful that I have these tools and the lab, which is a beautiful tool that I don't see being used in our area. And so it is extremely important that we have this information, because she did not look like what her labs told me was her internal environment. And I even told my colleague on the phone, I said, listen to what her insulin resistance score. So why do I care about that? Because high blood sugar, insulin resistance, prediabetes is literally gasoline on an arterial fire. I feel like that is the way underappreciated culprit in many heart attacks and strokes, because unfortunately, the traditional approach, this management paradigm we've got out here, has created a passivity on the part of many healthcare professionals, and certainly a passivity on the part of all of you, because you think, well, they're not upset. Why should I get upset? Well, honey, I'm upset. It's something to be upset about. And I am so thankful for this precious lady and how my colleague and I were able together to tag team and help her. So we're turning that bus around. We're using those medicines for as long as we need to use them to accomplish our goal. And then when we feel comfortable, we can taper, we can reduce doses, we can tweak it. We're using supplements. We're using everything we've got in our toolkit. We'll repeat her carotid artery or CIMT testing. We'll repeat it in 1 year. And I will come back and I will do a video, and I'll even ask that lady if she'll come do a testimony, and we'll talk and share her amazing praise report, because I feel convinced she's going to do awesome. When I met with the patient in person, I'm pretty sure it was yesterday, she said, I knew I didn't feel well. And I can't remember how she ended up coming here. I think it was one of her friends that sent her my way. But I'm so thankful that we met and were able to connect and turn her around. But these are things you need to be asking for. You need to be expecting a level of thoroughness in your yearly blood work, and that you're also to expect a thorough interpretation, not just told the F word over the phone that everything was fine. I just despise that. Patients being disrespected as if you're a toddler and cannot understand the basics about everything. You need to say, no, I need a copy of that. And then if you have a question, you call them back and just pester them until they get on the phone with you and give you the information that is yours to have. Or say, no, I'll be coming in to have a discussion in person about my results, because that's what I do. We spend a whole hour, if even more is necessary, we'll go longer. But so that you hold your very own copy like you're a grown-up, and I sit and we say, what does this mean? If we see a number we don't like, we talk about how do we fix it? What does this mean? What is this saying about my body? What do I need to do? And then I'm here to be a partner on that journey. So I mentioned in the previous video, we talked about whole food diet. That applies here. I'm not about starvation. I think that's so silly. I don't want us to be afraid of food. Food is a very important tool. And I know that we celebrate around food. I know we center lots of social activities around food, and it's super hard to encourage people to make really lasting changes in what they're eating. And I appreciate that. The other thing that's a super useful tool in addition to a healthy whole food diet is intermittent fasting. I just want to say this one last thing before we close. Intermittent fasting is actually a legitimate scientific modality that we can use not only for reversal of chronic disease, but there's wonderful science to support its benefits just for longevity and anti-aging. So I'm like, sign me up for longevity and anti-aging. So thanks, and I'll see you soon.